So, how are you doing, guys? With you today, Dr. Muhammad Hamid, an ECVMG certified physician, and today we're gonna continue our discussion about the pharmacology from the first aid for the USMLE Step 1 exam. So, we will talk about receptor binding. So, this we have like three curves here for different kind of competitive antagonists versus non-competitive antagonist versus partial agonist. So the first here, curve here is like competitive antagonist here for non-competitive antagonist, and the third one is for the partial agonist. So it is on the x-axis is like the dose, the different kind of the doses that we give, and as we go to the right, gonna increase. And on the y-axis is like the maximum effect. So the maximum effect from our previous episode is like translates into something called efficacy, and the dose translates to something called the potency. So first, the competitive antagonist. The competitive antagonist, here we got this line. This is the agonist plus the competitive antagonist versus line for the agonist alone. So if you notice here, both of them is gonna reach the maximum effect, which is 100. So the competitive antagonist will not affect like the efficacy. It is competing with another drug, for example. But if you increase the dose, you're gonna get the maximum effect also, but at a higher dose. So this translates to decrease in the potency. What we mean by decrease in the potency is like we need like a higher dose to reach the effect. So this is a distance between the two lines here is like the reduction in potency. So this line is like reduced potency. So this is a competitive antagonist, and we can be overcome by increasing the agonist concentration. So if we increase the agonist dose, we're gonna reach the maximum effect. Example for this is like diazepam, which is an agonist plus flumazenil, which is competitive antagonists. They both act on the same receptor, and hence they are competing against each other. And this receptor is GABA A receptor. So if you increase like the diazepam toxicity, for example, if you give, so you need to give so much flumazenil because like there's competition between them. So this is for competitive antagonists. Next is like non-competitive antagonist. So what is different between the competitive antagonist is and the non-competitive antagonist? Unlike this line here, which reaches the maximum efficacy, this agonist plus non-competitive antagonist will not reach the maximum effect. So watch out for this orange line here. It is like not gonna like reach the maximum effect, and the difference between both of them, the original curve and this curve, is like the reduction in efficacy. So the non-competitive antagonist is gonna like decrease the efficacy, and the potency, on the other hand, there is no change in the potency. They are not like not competing. They are competing with each other, but there is in the term on the form of like non-competitive antagonists. Some of the receptors are already blocked, and whatever the substance or whatever agonist dose you're gonna increase, you will never reach the maximum effect. So so this cannot be overcome by increasing the agonist concentration. And an example for this norepinephrine, which is agonist plus something called phenoxybenzamine. This is non-competitive antagonist on alpha receptor. So if you give phenoxybenzamine as a non-competitive antagonist on alpha receptor, whatever dose of norepinephrine you increase, you are not gonna like produce the maximum effect of norepinephrine. Our third curve here is like the partial agonist. So there's like in the decrease in efficacy also, but it has like different efficacies for different partial agonists. Some are stronger, some are weaker, and so this for example, this line partial agonist, this is the maximum effect for this partial agonist, and this is a maximum effect for another partial agonist. So this difference is the reduction of efficacy between them, and the potency potency is like independent of the potency. So the one who affects the potency is like the competitive antagonist versus non-competitive antagonist and the partial agonist. They will affect mainly the efficacy. So this like acts on the same side as a full agonist. So our famous example here is like morphine, whereas like full agonist effect is on the mu receptors versus buprenorphine, which has like uh, partial agonist effect. Also, it is agonist. It is blocking some receptor and getting like sub-threshold maximum effect. So if you give like buprenorphine and increase the dose of morphine, you will not gonna reach the maximum effect. So the efficacy translates into decrease in the efficacy. Our next concept here is the therapeutic index. So for the therapeutic index, it's like reflects or a measurement of the drug safety. So it's gonna be like the median toxic dose over the effective dose. So up here we got like the toxic dose, and here down we got like effective dose, and the difference between them is like the safety margin here for our drug is like the therapeutic index. So this is like the curve, the red curve for the toxic dose, the toxicity, and this the blue curve is for the efficacy, and between them is like the therapeutic index. We get therapeutic index by dividing the toxic dose TD, toxic dose 50%, which is the median toxic dose, over effective dose 50, like the median effective dose. Another term is the therapeutic window. So the therapeutic window is like when you give a drug, you have to like balance between safety and efficacy. You have like to reach the effective dose you aim for and like fight the disease at the same times. This don't need to be like at the expense of the safety. So it is like inherent for each different kind of drugs. So for example, there are some drugs that are famous for toxicity, such as warfarin toxicity is very famous, Marivan toxicity, and cyophyllin also very famous, as that it has like narrow therapeutic index. Digoxin toxicity very famous as Marivan toxicity or warfarin toxicity. Any epileptic drugs in the ICU, for example, frequently you check a banutin level, which is a famous anti-epileptic drug. So and the lithium. So as these drugs have like low therapeutic index, you're gonna notice that during your medical practice, you gonna like watch for their toxicity or for their level. Warfarin, cyophyllin, digoxin, any epileptic drugs, and lithium. So and again, therapeutic index TED 50 over ED 50. So, and this is like the efficacy, and this is like the toxicity, and the difference between them is like the therapeutic index, and this is the effective dose, median effective dose, and this is the median toxic dose. So the median toxic dose is if you have like a big gap between the median effective dose. So this is a log for the drug concentration. Here's the dose versus like the patient responding. So if you have like a big gap between them, this give you a little much high space for safety, for example. So next topic here is like some terms you have to like to know. For there's some terms that relates to the like interaction between different kind of drugs. First, additive, so permissive, synergistic, potentiation, antagonism, like tachyphylaxis. So first, additive, very simple. You add like substance A and substance B, and this is a simple addition, simple mass 2 plus 2 equals 4. Aspirin will it's gonna be like anti-inflammatory plus acetaminophen, also anti-inflammatory. So anti-inflammatory plus anti-inflammatory, you gotta get like addition of the action of both of them, very simple. And the next is like permissive. So this is different from additive. Effect is like some drug is required for the full effect of the substance B. So we are here talking about catecholamine responsiveness, how much is gonna like vasoconstrict vessels, for example. So cortisone itself is needed for the full effect of the substance B. In the absence of the cortisol, catecholamines are gonna like vasoconstrict the vessels, but cortisol presence is like permissive. It will permit like catecholamines to reach like the maximum responsiveness. So this is for the permissive effect. And this substance is gonna be required for the full effect of another substance. And the synergistic is like instead of a simple addition such as this term additive, synergistic like A plus B is equal than the summation or the addition of both of them. For example, clopidogrel plus aspirin. So clopidogrel plus aspirin is more effect is more than like the simple addition of both of them like combined. Effect of substance A and B together is greater than the sum of their individual effects. So this is for the synergistic. Synergistic is like additive but more powerful. You gotta remember it this way. So this is for the synergistic. The potentiation, it is like similar to the synergism, but drug B has no therapeutic action alone. For example, carbidopa, the famous example, carbidopa, levodopa, you give like combination of them. Carbidopa will block like enzyme, prefer conversion of levodopa. This will leave like much levodopa to reach through the brain and get the desired effect. So this is like potentiation, not synergism. Synergism, the two drugs are effective, both of them are effective, but potentiation, one drug is gonna like have no therapeutic action, but it's like, for example, carbidopa is gonna block the peripheral conversion of levodopa and leave levodopa to the rich for the brain. Antagonism is very simple. Morphine and naloxone, the sum of them is less than addition of them is less than the sum of both of them. We're not gonna talk about that. Very simple. Effect of substance B and the A together less than the sum of their individual effect. But here tachyphylactic. You remember the famous example of the oxymetazoline. Oxymetazoline, like you when you give like intranasal decongestant, you have to warn your patient to use them for 4 or 5 days. And instead, after the patient got like marvelous effect and he's improving, and he will watch himself, for example, gonna go back again at the same problems because decreased therapeutic response with rebound congestion. This is like tachyphylaxis. Tachyphylaxis, it means like means acute decrease in response to a drug after initial or repeated administration. So after initial or repeated administration, you got like acute decrease in response after a specific period. For example, our example of oxymetazoline for like rhinorrhea or congestion. So you're gonna watch for this tachyphylaxis. Our next big topic here is like autonomic drugs. So autonomic receptors or autonomic drugs. First, you have to know that our body is divided into somatic nervous system and autonomic nervous system. This is like the two big division. And the somatic nervous system is gonna like have like one nerve is gonna go into the neuromuscular junction and affect the skeletal muscles. So this is very straightforward process. And the autonomic nervous system is actually subdivided, of course, into parasympathetic and sympathetic nervous system. And the difference between them, like from secondary school and the middle school, like the preganglionic are short in the sympathetic, and the postganglionic fibers are long. So the sympathetic chain like lies close to the spinal cord, so we will have like long postganglionic ganglionic neurons, which are pretty long, versus the parasympathetic, which has the opposite. It has like preganglionic long neurons and short postganglionic neurons. So this is the first difference, and you have to watch that the uh, intermediate chemical is like acetylcholine between the preganglionic and the postganglionic. So here's acetylcholine, whether it's sympathetic or parasympathetic. The acetylcholine, and the adrenal medulla, of course, is gonna we're gonna consider it the first receptor in this first chemical mediator between like preganglionic sympathetic and the adrenal medulla. Also acetylcholine. Also here is acetylcholine. This is first you have to know. And the terminal receptor or the terminal chemical mediator that mediates the effect is gonna be different. So for the sympathetic nervous system, mainly it's gonna be like norepinephrine, and for the parasympathetic nervous system, mainly it's gonna be acetylcholine. And of course, it's gonna be acetylcholine also for the somatic nervous system, but the difference is that it is called NM receptor. NM receptor versus the NN receptor for this acetylcholine here. This NM receptor is the neuromuscular junction There's a norepinephrine, except one exception is like acetylcholine being used in sweat glands. So this is sympathetic supply, and it controls the sweat glands, and you have to very careful that it is acetylcholine is a chemical mediator, here very very unique. Also, it is sympathetic supply for the sweat gland. It uses acetylcholine. So you have to know like some nerves are part of the parasympathetic nervous system. The pelvic splanchnic nerve, we will talk about this further, and you have to memorize very well the cranial nerves, which are part of the parasympathetic nervous system. Cranial nerves 3 and 7 and 9 and 10. So 9 and 10 and 3 and 7. 9 and 10 and 3 and 7. So it's a part of the parasympathetic along with the pelvic splanchnic nerve. And the adrenal medulla is directly innervated by like preganglionic sympathetic fiber. So this the adrenal medulla, preganglionic sympathetic fiber, it uses acetylcholine as a mediator. So and so the sweat glands, as we have just said, they are part of the of the sympathetic pathway. So this is the sweat glands controlled through the sympathetic pathway here, and they are innervated by cholinergic fiber. So typically, the sympathetic pathway uses norepinephrine, but here it uses acetylcholine. An exception, just know that sweat gland sympathetic supply. So, and you have to watch that the same glands and the same cardiac muscles which are innervated by parasympathetic supply are also innervated by sympathetic supply, but it is the different receptors, different chemical mediators, and different like alpha 1, alpha 2, beta 1, beta 2 versus M1 to M5. So it's like you have to think of this like there is a switch and the counter switch, something increased salivation, something decreased salivation. So there's a balance between sympathetic and parasympathetic supply. So to recap, acetylcholine receptor here, there are nicotinic acetylcholine receptor and the muscarinic acetylcholine receptor. So muscarinic acetylcholine receptor first are G protein coupled that usually acts through like second messenger like M1 to M5, different heart to smooth muscle, brain, exocrine gland, sweat glands. So this is a muscarinic acetylcholine receptor versus nicotinic acetylcholine receptors, which are instead of being a G protein coupled, they are like ligand gated channels acting so through the efflux, which is going out of potassium, and the influx of sodium. So this is nicotinic acetylcholine receptor. This is like the nicotinic acetylcholine receptors here in the between preganglionic and the postganglionic, act like through ligand gated channels. So the efflux of potassium and the influx of sodium, and like in some cases calcium, there is all NN and NM. NN found in autonomic ganglia and adrenal medulla. So this is NN, yeah, adrenal medulla and autonomic ganglia, and NM found in neuromuscular junctions. Remember? So this is nicotinic acetylcholine receptor versus muscarinic acetylcholine receptor. So this is muscarinic acetylcholine receptor, and also this is muscarinic acetylcholine receptor. So they are like have from M1 to M5, and the like the mode of action of this receptor is J protein coupled versus like the nicotinic acetylcholine receptor, it depends on ions, so hence it is ligand gated channels that efflux that depend access through the efflux of potassium again and the influx of sodium versus the muscarinic, which are J protein coupled receptor. So the next topic here is micturition control. So the process of micturition is regulated primarily through the bones, like the main center that regulates the micturiation and regulates like the involuntary bladder function versus the voluntary, as we will go further. Via like the coordination of the sympathetic and the parasympathetic nervous system, this is centralized in the bones. First, this is the first piece of info you have to know, and you have to know that the sympathetic system, of course, is like the fight and the flight response. So you don't have time for example. So it will increase urinary retention versus the parasympathetic. When it acts, you have more the whole time in the world to be. So it increases urine voiding, and we're gonna make use of that by giving like some drugs that will control our voiding problems by acting on some like the sympathetic and the parasympathetic system. But first you have to know like the different kind of distribution. So first This is like when you initiate micturition, it's like under your control. So this is done like through the pudendal nervous somatic input. So this acts through like the external sphincter, urethral sphincter. This is first. Second, it's like the pelvic nerve. Remember the pelvic nerve, we said that it is part of the parasympathetic input, and the parasympathetic uses M receptor, muscarinic receptor, and here's like we have like M3 receptor. So M3 receptor as a part of the parasympathetic input here, controlling the like the bladder muscles. So remember we said like parasympathetic sub input will give you make you like increase urinary voiding. So it is positively stimulated, it will increase voiding, and if it is inhibited, it will get like will not make you void. And as an application, we got like two drugs. They're muscarinic agonists and the muscarinic antagonists. So the muscarinic agonist, our example is bisanicol, and it is positive on M3. Remember that we said this muscarinic parasympathetic makes you B, and it makes you B, so it is used in urinary retention. We got urinary retention, so we gonna like stimulate the parasympathetic system through the bisanicol, which is muscarinic antagonist through M3 receptor. It's gonna make like detrusor muscle contract and hence increase bladder emptying. First, and on the other hand, remember famously the famous problem in young children, urge incontinence. It is all the whole the opposite. We're gonna like give muscarinic antagonists such as oxybutynin. It's gonna inhibit M3 receptor, and it's gonna relax the detrusor smooth muscle and stop like urge incontinence and decrease the detrusor overactivity. The second, this is like pelvic nerve, which is carries our parasympathetic input versus hypogastric nerve, which carries sympathetic input. The hypogastric nerve is further subdivided to cover two parts of urinary bladder. First is the muscle itself, the bladder muscle itself, and second is the sphincter. But remember, this is pudendal nerve who supplies like external urethral sphincter under your control versus the internal urethral sphincter, which is supplied by a branch from the hypogastric nerve, which carries like sympathetic input. So if we give like sympathomimetics, for example, mirabegron, remember sympathomimetic, remember the sympathetic nervous system will makes you increase urinary retention. So we are given here like sympathomimetics. So it's gonna retain your urine. So it is used in treatment of urge incontinence. So this is mirabegron used in the treatment of urge incontinence. It stimulates the B3 receptor, is gonna relax the detrusor smooth muscle. And our last drug, which is very famously known, which is tamsulosin alpha 1, like alpha 1 antagonist. So this is part of the sympathetic system controlling through the controlling the internal sphincter for the urinary bladder through the alpha 1. So if you give like alpha 1 inhibitor, you're gonna for example relax the smooth muscle of the bladder, neck, and the prostate, different parts part of the urinary bladder. So you're gonna decrease urinary obstruction. So the tamsulosin, which is alpha 1 antagonist, is very famously to be used in benign prostatic hyperplasia. Our last topic here is like tissue distribution of the different adrenergic receptors. So the adrenergic system works through different receptor alpha 1, alpha 2, beta 1, beta 2, and beta 3, and they are distributed in different tissues. So for the alpha 1, it is distributed in the vascular smooth muscle and the visceral smooth muscle. Alpha 1 is famous for causing contraction. So if it acts on vascular smooth muscle, it's gonna cause vasoconstriction. On the visceral smooth muscle, it's gonna cause smooth muscle contraction. This is for alpha 1. So for alpha 2, it is inhibitory, unlike alpha 1, which is vasoconstrict. Smooth muscle contraction is inhibitory. So it is distributed in the pancreas. So here in a fight flight as a part of the parasympathetic. So alpha 2 is gonna inhibit the insulin secretion. No need for insulin secretion. On the presynaptic terminal, so it's part of like a feedback between in the presynaptic and the intersynaptic, and we have like the intersynaptic between them space, and the presynaptic terminal have like alpha 2 receptor, which is gonna inhibit neurotransmitter release. So it remember, as a rule of thumb, alpha 2 is inhibitory. On the pancreas, inhibition of insulin release, they are found on the presynaptic terminals. So it's gonna like inhibit neurotransmitter release. Salivary gland also is gonna inhibit salivary secretion. So sympathetic system, fight or flight, no time for salivation, so salivary gland. The beta 1 and beta 2. So you know that the heart is supplied by beta 1 and beta 2. So the heart is found here in the beta 1 and the cardiac muscle here, and its action is the same. Increase heart rate and the contractility, increase heart rate on the contractility. The rule of thumb, heart is supplied by beta 1 and beta 2. What is different here is that the kidney is supplied by B1. You have to memorize that the kidney is supplied by B1, and the action is gonna lead to increase in the renin secretion. So the sympathetic nervous system is gonna increase the renin secretion, renin angiotensin, and at the end is gonna increase blood pressure. So it starts through the kidney and through the receptor of B1 receptor. Very you gotta memorize this part. And the very famous, you have to watch the very high yields that bronchioles are supplied by B2. Very famously assessed in exams that bronchioles are supplied by B2, and this sympathetic stimulation is gonna cause like bronchodilation. So to apply this info, when you give like non-selective beta blocker, it is contraindicated in asthma, because if you give non-selective beta blocker, is not gonna block the heart only, but it also is gonna block B2, so it's gonna cause like bronchoconstriction, and which is has deleterious effects for the asthmatic patient. So the bronchioles have like B2 receptors, and the B2 B2's role is like bronchodilation, and the liver is supplied also by B2. So sympathetic system action on the liver is gonna increase glycolysis, glucose release. We want to use glucose for fight and flight, and the arterial smooth muscle. It is the opposite, is gonna cause vasodilation. So remember that alpha 1 has the main effect of the sympathetic nervous system on the vessels is like vasoconstriction, which is through the V alpha 1 acting on the vascular smooth muscle causing vasoconstriction, versus P2 acting like on arterial smooth muscle causing vasodilation. And the pancreas also the opposite to alpha 2. Alpha 2 on the pancreas causing inhibition, so alpha 2 here is causing stimulation. So it's like stimulatory. You remember that alpha 2 is inhibitory. B3 found only in adipose tissue, it's gonna increase lipolysis. So we come to an end of this discussion about the pharmacology part B for the pharmacology for the USMLE. I hope you guys enjoyed this video and learned it a lot, and see you in next episodes.